Hello class, this is Drashella Lespinas. I'm here today to talk to you about my case presentation on vaginal discharge. But before I begin, I'd like to first address my case. In this particular case presentation, it's of a 43-year-old married Hispanic female with a chief complaint of excessive vaginal discharge after sexual intercourse associated with a strong odor for the past 3 days. Now, when we look at these different things as far as this case presentation, we want to first be able to learn how to gather specific questions that are associated with characteristics of the symptoms the patient has talked about. And this is indicative of her chief complaint. And some of these questions I'll be looking at is asking of the onset. I want to know the location of the discharge, whether if it's vaginal or rectal, the timing and frequency. I want to know of any triggering factors associated with it, any alleviating factors that the client may have. I want to know pain associated with the discharge and any effects on the daily life. Now, in this particular fictitious case study, the onset of the complaint was 3 days after having sexual intercourse. It was noted that their discharge was gray to greenish in color and that there was an odor. There was no pain, but there was irritation of the vagina with sexual intercourse. The symptoms were not associated with the menstrual cycle, and there was no itching or burning in the vagina. Now, after I gather this information, it's very important to get a complete medical history, and the medical history needs to be both general and specific. Now, when we look at the general medical history, I'm looking at current medical problems, I'm looking at past medical problems, I'm looking at past surgeries, current medications, any allergies, I'm looking at family history and any social history. So in this particular scenario, there was no current medical issues or problems. There was a past medical concern of candidiasis. There was no past medical surgeries. The current medication the patient mentioned was having birth control, but was a poor historian. Couldn't say what type, but that it was an oral birth control. Allergies were to aspirin, and that there was a family history of hypertension on mother's side. The patient also verbalized using marijuana on the weekends with her husband. And when we look at medical history that was specific to the complaint the patient came in, I want to know about menstrual history. I want to know about the history of numerous sexual partners. I also want to know if there's any unprotected sex, and also any history of STDs in the past 2 years. In this scenario, the client had her menstrual onset at age 12 and has a history of sexual partners of 5 in her lifetime. She did mention about having unprotected sex prior to being married, but since that time has been with one partner only. There is no history of STDs in the past 2 years. Once we gather the medical history, it's very important to then move to the physical exam. And within the physical examination, it is important to provide inspection and palpation of the external genitalia, and then from there leading then to the physical examination of the findings. So in inspection of the external genitalia, it's important that it be noted to find some mild redness, some irritation of labia. There would be no swelling or blood noted, no tenderness noted on the inguinal nodes, and that there will be a thick, milky, and grayish in color vaginal discharge with a fishy odor as noted in the picture below. Now, when the physical examination is completed, in this particular scenario, the vitals were within normal limits. The general appearance of the individual was healthy, the skin was warm, dry, no lesions, hygiene good, the weight was about 140, the height 5'5", and the number of sexual encounters were at least one time per week with her husband, but there was no lubrication that was used. Last pap smear was 1 year ago, which was normal, and of course there was a milky gray color discharge that was fishy in odor, but there was no pain or blood. From here, it's very important then to move to what could be a possible diagnosis and differential diagnosis. It's important to realize and know that for most women have vaginal discharge, and the idea of having vaginal discharge can be very bothersome for many women, but it's important for advanced practice nurses and nurse practitioners to let our clients know that a clear discharge is more indicative to having a healthy flora in the vagina, and that's pretty normal. And a grayish color can be indicative of bacterial vaginitis. A pinkish tinge can be a cervical bleeding or vaginal abortion, or it can be even implantation of a pregnancy even. Whitish color discharge can be more of a yeast type of infection. A yellow, greenish color can be more conclusive to having a sexually transmitted disease. And bright red can be more close to having more closer to menstruation, cervical infection, cervical polyps, or even cervical cancer. So those are some ideas of vaginal discharge that's very common to most. Well, at least a clear is. Clear color discharge is common to most. But then when we talk about possibly other vaginal discharges and what causes it, there can be other differential diagnoses such as atrophic vaginitis. It could be a foreign body that's there. It can be contact dermatitis, or it can be a physiological discharge. But for the sake of this presentation, I'm going to focus on three main ones, and I'm going to focus on Candida, trichomonas, and also bacterial vaginitis. And so let's move real quickly into that. So Candida, as this picture you see here is so nicely done, there is a discharge, as you can see, and to the left of this picture, you can see that there's a cheesy white discharge. There is no odor. There is pain on intercourse, especially around the vulva, and other symptoms include itching, burning, and swelling as well. When we move to trichomonas, trichomonas has more of a green, yellow, frothy type of a discharge, as you see in this picture here. It is very foul smelling, and there is pain on urination, and there also may be itching and also burning as well. Then when we move to bacterial vaginitis, bacterial vaginitis has a discharge. It is white, gray, or yellow in color. The odor is more fishy. There's no pain, and other symptoms associated could be itching, burning, or redness and swelling of the vagina as well. The difference with bacterial vaginitis is a little different than having Candida, is because Candida is more cheesy, as you remember from the other picture. It's more cheesier type of looking, and this is not as cheesier in the look at all whatsoever. So when we look at all these different things, we then lead to what can be our primary diagnosis for this case study that was presented. But before we do that, get to our primary diagnosis, let's do a quick recap and look at and do a case analysis. So in the study that was presented, the patient reported having a milky gray fish-smelling discharge for 3 days. There was a regular menstrual cycle, and there was no pain with sexual intercourse, no itching, burning, or swelling of the vagina, and she had no new sexual partner. It was just her husband. So based on this, it is more indicative of having a primary diagnosis of bacterial vaginosis. So bacterial vaginosis has a pathophysiology that leads from the replacement of hydrogen peroxide producing organisms with high concentration of anaerobe bacteria in the vagina. This type of anaerobe bacteria in the vagina leads to a pH that becomes more elevated, creating more of an alkaline environment. And this type of alkaline environment encourages growth of certain type of cells that stick to the vaginal walls. The anaerobes facilitate the release of the amines, which produces the fishy odor. So those are some things that are associated with the pathophysiology of it. But once we have that, we then need to look at, okay, how can we confirm it? Well, that could be done by testing. The diagnosis of bacterial vaginosis can be made by clinical criteria. The clinical criteria requires the presence of 3 of the following. It requires non-inflammatory discharge that sticks to the vaginal walls, whitish color like I mentioned beforehand. And it also it requires a pH of the vagina fluid to be above 4.5. And also the vaginal discharge to have a fishy odor before and after the addition of potassium hydroxide, which is otherwise known as KOH. And that then provides a positive whiff test. So as you see here, I've given you the 3 different testing. The KOH, which is the potassium hydroxide testing, the pH testing, and the wet mount. These are the 3 major ones. I've also provided the procedure code, which is also important to know because as working in a clinic, it's important to know which code that you need to bill for. Something else that's very, very important is looking at the costs, which is also something that I include here. As advanced practice nurses, as we are working in clinics, it's very, very important to know which testing to utilize that won't cost our clients more money. And in looking at this, the pH testing, which is a very simple test with the cost of $7.09, is done by using the litmus paper. And with that, then vaginal secretions are placed on litmus paper, and if the pH is higher than 4.5, then that can be more indicative of atrophic vaginitis or even bacterial vaginitis as well too. Usually a pH of 4.0 to 4.7 is more consistent with Candida. So these are some of the different testing that we can use to help determine whether or not a patient has either a STD, or if it's more of a yeast infection, or if it's just a bacterial vaginitis. Some of the treatment plan. Recommended treatment for non-pregnant women includes using metronidazole 500 milligrams PO twice a day for 7 days, or by using the gel with a full applicator intravaginally once a day for 5 days. Other alternative regime could be used for clindamycin 300 milligrams PO twice a day, or we can use a clindamycin Ovolus that can also be used intravaginally every night at bedtime for 3 days. Now, for pregnant women, metronidazole 500 milligrams PO twice a day for 7 days can be used, or 250 milligrams PO twice a day for 7 days. Clindamycin for 300 milligrams PO twice a day can also be used for 7 days as well for pregnant women. It should also be noted that for those who have recurrent bacterial vaginosis, that it's important to use alternative first-line agents and prophylactic use of intravaginal metronidazole twice a week for 4 to 6 months, and that's a little bit longer. So basically, a person, you'll be having them using it much longer, twice a week, and that's for those who have recurrent bacterial vaginosis. Patient education, which is hugely important, and this is what our specialty is as nurse practitioners. It's very important that we let women know that bacterial vaginosis is one of the most common causes of vaginal discharge among women, and that many women are asymptomatic. We also need to let them know that bacterial vaginosis reoccurs within 1 or 2 months for many women. And we also need to let them know that it's very important for them to complete the full course of treatment to prevent regrowth of the bacteria. Hugely important. It's also important for us to let women know that they should avoid douching. A lot of times women think that they need to douche, but in actuality, the vagina has a way of self-cleaning itself, and providing this education is hugely important. We also need to remind them that perfume or scented vaginal cleansers or sprays and wearing loose-fitting clothing is best, but preventing the perfume and scented vaginal cleansers, of course. We also need to remind them that having safe sex practices, and that includes reducing the number of sex partners and using condoms as well too. Hugely important, and remind them that being on birth control does not prevent them from getting bacterial vaginosis at all. We also need to remind them that if they become pregnant, that what are the signs and symptoms of preterm labor. It's noted that bacterial vaginosis can cause preterm labor in pregnant women, so we need to educate them on signs and symptoms of preterm labor. We also need to let them know the common side effect of oral metronidazole, which can be gastrointestinal upset, and that can create some problems for some women. We also need to let them know that they need to avoid taking metronidazole while drinking alcohol to prevent nausea and vomiting, at least for 24 hours. Lastly, we also need to remind them that oral clindamycin is just as effective as oral metronidazole, but it's more expensive, and it also can cause diarrhea. Some of our clinical practice guidelines for our clinics: we need to let all women with bacterial vaginosis know that they should be tested for HIV and other STDs. It's very common for bacterial vaginosis to reoccur with women who have HIV, so we really want to encourage our women to have these testing on a regular basis and provide the education. We also want to let women know that they need to follow up. Follow up in the clinics is not necessary if symptoms resolve, meaning that their discharge and the odor relieves itself. It's not important for them to follow up in the clinic. It's also important for us to let them know that that is not that oral metronidazole 2 grams may be administered with fluconazole 150 milligrams for suppressive therapy for women with recurrent bacterial vaginosis, and that can also be done. And so there are options for them if they have recurrent. We also want to remind them that we don't necessarily have to provide routine treatment of sex partners. A lot of times in other STDs, and this is not STD, but in a lot of other things, their partners have to be treated as well. But in this situation, it's not necessary. And we also want to let them know that intravaginal cliamycin cream is preferred in the case of allergies or intolerance to metronidazole, and so that there are still hope if they have allergies. We also want to let them know that treatment is recommended for all symptomatic pregnant women. Can't stress that enough, because as we mentioned previously, they can go into preterm labor. So that's very important that we stress that to them. And lastly, as I mentioned before, about the reoccurrence for those women who have HIV. That's something we need to remind them as our clinical practice guideline. This ends my presentation on the vaginal discharge, and this is my reference. I thank you for paying attention and for listening.